Got it. I hope. All right, good morning, everyone. So as Janaki said, and as some of the previous speakers alluded to, I'm here today to talk to you about a new survey program that we've got under development at the National Center for Health Statistics. It's one that emphasizes timeliness and relevance and focusing on emerging and priority health topics. And it is a program that we're calling the Rapid Surveys System. Now, the need for timely data, the need to improve timeliness for our existing data is certainly not new. But the pandemic emphasized how important timely data can be for decision making. NCHS did not have a mechanism to quickly collect data from personal interviews. Nobody in the federal statistical system did. Traditionally, as Ari, said at the beginning, NCHS and other parts of the federal statistical system generate robust, nationally representative statistics using methods that rely on gold standard sampling and interviewing and post-processing, all to maximize accuracy and reliability. Those are pivotal in our minds to examining yearly trends at NCHS, yearly trends in disease or in behavioral risk factors. But these are not particularly useful for responding to short-term challenges to public health. During the pandemic, instead, CDC turned to other data sources, sometimes licensing data, often with unknown quality. And, I would say that the implications of using data of unknown quality became clear in a number of cases. So in response, Dr. Walensky, the CDC director, launched the CDC Moving Forward initiative to improve accountability and timeliness, to develop and institutionalize new systems, processes, and policies that will enable more time-sensitive data, more time-sensitive sharing of data, and sharing of scientific findings that are suitable for decision making. At NCHS, the closest thing that we had to, a quick turnaround survey was RANDS, which Paul just told you about. And so I'm going to skip over these slides here, except to say that building on RANDS and the lessons that were learned and the successes that came from RANDS, using commercial probability-based online panels, the Rapid Surveys system will also take advantage of these survey panels. We're also going to bring NCHS's approach to these commercial probability-based online panels. So, we're going to bring our expertise, our credibility, and our values. And we're going to look to maximize accuracy and representativeness by collecting data from multiple survey panels and drawing upon NCHS's core surveys for calibration. We're going to be completely transparent about the quality of our data, carefully documenting and publicly releasing reports on the strengths and weaknesses of the data, which we'll be able to do because we will own the data as opposed to licensing it from the data collectors. And we're going to value accessibility. So the program will be accessible to CDC partners who need data on new, emerging, and priority health topics. Also, the results will be posted online. Public use data files are going to be freely available to CDC programs and to the public. And the Rapid Survey system is going through OMB clearance. and we have OMB's support, and we're working with OMB to put in place processes that will let us be timely and relevant. So this slide that I've had up now for a little while shows the key characteristics of the rapid surveys system. I'm going to walk through some slides here on each of the bullets. Obviously, for this audience, I don't need to tell you what a commercial probability-based online survey panel is. But the point that I do want to make for the rapid survey system is that we will be simultaneously using two panels, both Knowledge Panel and Amerispeak, two of the most well-established and scientifically rigorous commercial panels that are available. And and one of our research questions is whether the sum of those two gives us something more than either of those panels would give us individually. We will be doing quarterly data collection. Plan is to include at least 4,000 completed surveys per quarter. But when we launch in July, we will be expanding that sample size. And so for quarter 3 and quarter 4 of this year, we're going to be including about 7,000 completed surveys using standard protocols. I say using standard protocols because the option is available to us within this system to use enhanced data collection protocols, such as pre-notification postcards and non-response follow-up that may be phone-based, phone prompts, telephone interviewing, or postcard-based non-response follow-up, as well as extended field periods to accommodate this non-response follow-up. And one of the questions that we have is whether the data that we get by putting in that extra effort, in fact, provide us with estimates that are more accurate and representative. And so in quarters 3 and 4, in each of those quarters, we will have about 6,000 additional completes with these enhanced protocols so that we can compare standard to enhanced. We partner with CDC programs to propose content. As we think about what the rapid surveys are particularly useful for, first and foremost are time-sensitive data needs, as I've been alluding, for which existing resources are unavailable, not timely, or of insufficient or unknown quality. And I focus there on the unknown quality and contrast it with what we promise, which is known quality, being transparent and making accessible information about the quality of the data that we're collecting. We do not say that we're going to be high quality. We certainly hope to be, but we do recognize that the rapid survey system is really intended for contexts in which decision makers have a need for time-sensitive data of known quality, and that is a higher priority, perhaps, than their need for statistically unbiased estimates. In addition, we think the rapid surveys will be well suited for collecting data on public health attitudes and behaviors. Our traditional surveys at NCHS generally do not collect information on attitudes and behaviors simply because the long period for data collection and for post-processing means that those estimates might be outdated when we're able to make them available from a traditional survey. And then we also think that rapid surveys will be well suited for developmental work, much like RANDS is. And Paul had shown you some examples of how these surveys can be used for developmental work. And we expect the rapid surveys will also serve that purpose. Now, what is it not well suited for? One is estimates that we're already producing using NCHS's cross-sectional surveys. Our goal is not to start putting out multiple estimates of the same constructs and having to adjudicate the differences between them and having multiple estimates floating out there. Because of the sample sizes, the rapid surveys may not be well suited for low prevalence estimates or estimates for hard to reach or low prevalence subpopulations. And then, in the advice that we've gotten from folks who have used the probability-based online panels, we have heard that we should discourage people from asking for content that's related to the data collection methods. Internet use, topics that are related to technology use, and then also estimates related to the willingness to participate in online panels. Most notably, we recognize that constructs such as civic participation and voting and volunteering are often overestimated using the online panels. Now, how do we know which health estimates are related to data collection methods or to willingness to participate in online panels? Well, we're going to be adding questions about these topics to the National Health Interview Survey in order to identify those health and healthcare measures that are correlated with these topics. Okay. I've been calling this rapid surveys, and that might be a little bit of a misnomer to some of you because, our definition of rapid in the federal statistical system is a little different than others. Our goal is to be able to produce estimates and have them available publicly in about 6 months, maybe 7 months after a CDC program comes to us and expresses a need for data. We will be using innovative methods for estimation. Yule already talked about the model-based sampling weights and how they're calibrated using data from NCHS's core data systems. One of the real advantages of running the rapid survey system out of the same division that runs the National Health Interview Survey, of course, is that we can add questions to the NHIS and create our own control totals for weighting. And so those measures, internet and technology use, civic engagement, not only are good for looking at relationships with measures on the survey, but we're also going to be able to use them as control totals in calibration. In addition, we've also added questions about use of languages other than English. And some of the preliminary evaluations from RANDS, Yule talked about this already, suggests that by calibrating to civic engagement, disability, and selected other health conditions, you can reduce bias, and he showed you that in his slides. Okay. I said that 2 of our key values are transparency and accessibility. What I mean by accessibility is the production of public use and restricted access data files, along with online dashboards, web tables with basic statistics. And we will be, as I said, transparent when it comes to information about data quality and limitations. Part of the reason of putting out the public use data files, like Paul said when talking about why RANDS puts out those public use data files, is to enable researchers to also take advantage of the methodologic work that we're doing and perhaps do some of your own analyses and let us know what you find when it comes to estimation or methods work. Okay. Talking about the evaluations of data quality, the key to these evaluations is the comparison to relevant benchmarks from NCHS core data systems. We're interested not only, of course, in bias, but also in distributions and relationships with other variables. And so we'll be able to look at how the data that we get through rapid surveys compares to the gold standard data that we get in the National Health Interview Survey and other NCHS core data systems. Much like Yule already talked about, we'll be evaluating alternate methods for adjusting, calibrating, modeling, combining, also considering the impact of those enhanced data collection methods on accuracy and non-response bias. All of this is to provide evidence for the fitness for the intended statistical and programmatic uses. If we think about what those uses are, we can turn to the goals of the rapid surveys system. First and foremost is what we've been talking about, and that is providing our partners with relevant and timely data on these new emerging and priority health topics, estimates that are fit for use for decision making. But a second purpose, perhaps a little less critical, but nevertheless important, is the ability to provide CDC and our partners with nowcasted estimates. So for topics that are on the NHIS, but for which perhaps more urgent, timely data are needed. A pandemic has hit. We need to know whether certain changes have now occurred in key indicators that we've tracked for a long time. We would like to see whether or not these rapid surveys are useful for detecting those changes. And finally, another goal is to carefully evaluate and communicate the fitness for use. All of this evaluation work is not only in service of the values of a federal statistical system in terms of being transparent and letting our data users know about the quality of the data that we're providing to them, but we're also doing it in order to demonstrate to the Office of Management and Budget that commercial online survey panels have a place in the federal statistical system, have a role in producing official statistics, so long as people are aware of their strengths and limitations. And so, yes, we recognize that what we're going to put out there is going to show that the estimates from rapid surveys are perhaps less stable due to the smaller sample sizes, that they're more subject to concerns about representativeness, but nevertheless are useful. When it comes to communication, though, we need to figure out how to the best ways to effectively communicate differences in quality between these estimates and others from NCHS. And so that's also part of the system goals. All right, I'm going to close there. I've already talked about that and blown past the X that's been shown to me. So thank you.